Good morning, all. I hope I'm audible. Hi, Ruby. So I'm going to take a session which you may wonder why I'm taking when you come for a workshop on regression analysis techniques. Uh, I think as we complete this 1 hour session, you'll understand why I'm taking this session. I'm Dr. Thambu. I'm a physician, so I was very happy to see a lot of general medicine people. So special warm welcome to all of you. I also work in the clinical epi unit in CMC, and I also help in the Cochrane CMC fellow. So this is a very nice article I came across, and these are in your slides. These are free articles to download if you're interested, by Thomas Vetter. I'm that old. I like the story Wizard of Oz. There's a girl called Dorothy, and she has a wonderful adventure. It's an old story, and she meets a lot of animals, or she gets to know that she may meet lions, tigers, and bears on her adventures. So you may wonder what's the connection with our workshop. During the next 2 days, you will come across these words very often: bias, confounding, interaction. So those are the animals you're going to meet in the next 2 days. So the 1 hour introduction is going to be on those things which you're going to use the software for. So it will help you during the workshop. So let us say you're trying to find out something. So madam, is there some research you're doing now? This is informal. Yes, you don't have to stand on. Okay, that's excellent. So let us say that what you're trying to estimate is the prevalence of stress, sits it, or the risk factors for stress. That is what is known as a sample estimate. So in this research equation, what you're trying to estimate, what you're trying to find out in research is called what the sample estimate is. There is something called the truth or the population parameter. That's what you're really trying to find out. That truth is mired by something else. There's something called a random error, which will muddy it up, and a systematic error. Random error is also called chance. And as you can see, there's on this graph, the x-axis is sample size, and the amount of error is on the y-axis. And as the sample size increases, this green line, random error, keeps decreasing. So all of you know this, if you want to reduce error in your study, increase the sample size. It's not that you can infinitely increase, and that's also a waste. Beyond a certain point, it's inefficient. And below a certain point, you're making a lot of random error. So you have to find the ideal sample size. The second kind of problem you'll land up is called systematic error. Systematic error is something at the end of your study you realize, oh, I made a big mistake. I can't undo it, right? So that's the whole game, is you should have as less systematic error as possible. So for your research, you must try to look, what are the errors I can possibly do? And that's why the amount of systematic error remains stable. Whether you have a small study or a big study, if you have made those errors are with you for the end of that research. And so that's a little bit about this. So what are those systematic errors? The first error is called recall bias. So if you are asking somebody, did you have a stressful life situation in the past? People with stress will remember every small detail of, my in childhood, my teacher scolded me, or somebody said something and I wetted my pants or something. But the person who doesn't have stress right now may not remember those things in the past. They might have had the same experiences. So there's a differential recall of what happened in the past. So if your risk factor is something in the past, unless it's documented somewhere, many of our observational studies have recall bias. Now, you'll notice that if the lights are on and the parent is there, the child may watch some different program on YouTube. At the moment everybody is not there, their behavior may change. And that effect is called the Hawthorne effect. So even in research, if you're studying stress or you're studying something and you're looking at people, they may behave slightly differently from when they're not being observed. So when you're collecting patient data, you have to be careful of this particular effect called Hawthorne effect, where they behave slightly differently. Or qualitative research, you ask them, have you had any of these experiences? And they're looking at you. They don't want to answer because everybody is saying something else. So be careful of that observational bias. The next one is called attrition bias. So you're studying a large group of people and you follow them up over 10 years. And suddenly you will find that some people are lost. So there are three ways people can be lost. So it's important to know this. One is that it's just chance. They just lost because they happen to go away. And if you study them, there's no rhyme or reason why they left. They have the same average age as the people who stayed back. They have the same gender, the same risk factors. Everything's the same. Just so some people just moved to another city or they went away somewhere. This is called missing completely at random. So the word is MCAR, missing completely at random. Where there is nothing. It doesn't affect your study much because it's normal. You can't follow up 1,000 people for 10 years and say all 1,000 will be there. Some people will move away. It's not death. They'll go away or they'll decide they don't want to be part of the study. That's missing completely at random. That's the first kind of attrition bias. The second kind of attrition bias is, let us say that it so happens that in your study, more women leave the study at the end. So that's not completely at random, but it's missing at random. So what is the difference? In the end of your study, if you find gender doesn't make a difference to the outcome, we'll say this missing data is not completely at random, it's missing at random. So there is a pattern. I can see that more women have lost, but it doesn't make a difference to my outcome. And the last kind of attrition bias is the terrible one where it's missing not at random. The outcome is largely determined by people who have childhood trauma. And most of the people with childhood trauma dropped out of your study because it was too painful or whatever reason. So then you have a big problem. Attrition bias becomes a problem. So that's a big problem when you have two groups of people you're following up and the loss to follow up is different in the two groups. That's also an attrition bias. Misclassification bias is slightly different from recall bias. Do you smoke, David? Oh, I can't tell Dr. Thambu I smoke. No, sir, I don't smoke. So in the research, he comes as a non-smoker, and I'm just saying for example. I clearly hope it doesn't happen, but he gets lung cancer, and we say, yeah, non-smoker got lung cancer. So the exposure is misclassified for whatever reason. You do a long randomized control study, you do a long cohort study, and you want to look for mortality. In many Western countries, they look at the Social Security website. If you died anywhere in US or any Western country, it'll pop up on your, if they log into the system, you know that so and so died. So if you're doing a large study of, let's say, 1 lakh people, you don't have to actually follow up every 1 lakh person every month, alive or dead. Look on that government website, you can make sure if they're alive or dead. But if you say in India that I'm going to follow up the municipal records to see death, we know that our record keeping is not that great. So we may make a mistake. So we may classify somebody who's actually alive as dead or dead as alive. We try to call up the person, no known details. What do you assume, dead or alive? So you may make even an outcome misclassification. Again, it's differential misclassification. If the people who give some treatment, they are all called alive and they may be dead, and the people who on the normal treatment arm or the usual treatment arm, you'd make the other bias. No, then they must have died. So the bias is not equal in both arms. It's non-differential if you make the same amount of mistakes in both arms. There are two treatment arms and you misclassify the same number in both arms. So that's a differential misclassification or a non-differential misclassification. Selection bias. Now I know that as a postgraduate or as a faculty, we tend to do research on the patients we can find. Why? Because it's easy. That's called convenience sampling. That convenience sampling doesn't reflect anybody. No, not the people of Vellore, not the people of Tamil Nadu or anybody. So if you choose the wrong people for your research, whatever else you do, everything will come wrong. It look very nice. Nobody will find any fault with your research, but you happen to choose the wrong group of people to study. That's called selection bias. So be very careful when you select your people. What's your question? Am I choosing the right group of people and how I select those people? So that's called selection bias. Now I'm going to speak a lot about confounding in a little while, but basically confounding stands for confusion. You say that, let us say E stands for the exposure or risk factor. Let us say E is obesity, and you say, or that is obesity and that is death. Death is the outcome. But maybe there is a confounding factor. Maybe all obese people have diabetes, and it's diabetes which is causing death, not just the obesity. So there's a confusion. What you conclude that obesity causes death may not be the truth. Maybe it's actually diabetes which is causing death. We'll talk much more about confounding in the future. Now, what is the problem with this confounding? Many observational studies, 90% of research done all over the world is observational studies, cohort studies, case control studies, just cross-sectional studies, retrospective studies, case series. They are full of confounders. So this is really the meat of this. If you don't collect good data on confounders, your observation study is often useless. So if you ignore that, you make a wrong estimate of this. You may wrongly assume that obesity causes death if you ignore all confounders. Some epidemiologists will say that if you can adjust for the confounder, and if the effect changes by more than 15%, whatever this effect, if you adjust for, let us say, obesity and diabetes, and you adjust it for, obesity and death, and you adjust it for diabetes, if this effect changes by more than 15%, then you say that's a confounder. Some other researchers will say 10%. So it depends on whom you ask. They'll say 10%. Some will say 15%. I'll talk much more about confounding. Now, I told you about selection bias, and I also told you about confounding. So there is something called a type 1 error. Type 1 error is, hey, we should all take Kira Nelly, that's a herb in Tamil Nadu for jaundice. It's very good. And we all say very good, very good. The truth is, I'm just saying, the truth maybe it doesn't work. But we conclude after our research it's very good. That is called type 1 error. So if you select the wrong group of patients, you may land up with a type 1 error. So a selection bias can also lead to confounding and wrong conclusion. Type 1 error is when you conclude something works or there's a relationship between two variables which actually doesn't exist. Type 2 error is the reverse. Kiranelli really works. But at the end of your research, you conclude that this herb doesn't prevent or treat jaundice. So again, if you choose the wrong people, sometimes you'll land up with a selection bias which affects confounding, which can lead to a type 2 error. Confounding by indication. So let me give you a story. So one of my colleagues, Dr. J.V. Peter, he was my senior and friend. He was in the ICU and I was in general medical ward. So we just said, so ICU is very costly. I'm going to manage all my sick patients in my general medical ward. True story. So after some time, he said, let's look at the data. The people treated in ICU and the people treated in ward, sick patients. And we found the ICU patients had higher mortality. So I was constantly poking him. Haha, see, your ICU is giving higher mortality, waste of so many intensivists, so much of money. This is confounding by indication. What happened? Among the patients, sick patients who came to my ward, very sick patients went to the ICU. Slightly less sick patients went to the ward. So the higher mortality in the ICU was because they was selected or sub-selected a higher sick group of patients. So my conclusion was ICU has more mortality than ward. It's wrong. Sicker patients went there. So a selection bias caused a bias. This is called confounding by indication. So some more words, some more animals that we are going to talk about next 45 minutes. One is called effect modification. One is called interaction. One is called mediation. Again, this articles which I put up here, I put it purposely like this because these are free articles. If you're interested in reading, just Google it, you can get the full article. So what is effect modification? To identify whether the effect of a treatment or exposure, exposure could be diabetes, no diabetes, smoking, no diabetes, no smoking. Treatment could be whatever treatment you're giving for a disease, whether that effect of the treatment is different in different groups of people. Does the COVID vaccine work better in young people or old people? Does it work better in diabetic or non-diabetic? If the effects are same in both groups, then you say the effect is homogeneous. If the effects are different, we call it heterogeneous. So I'll give an example. For the first example of effect modification, I'm going to use a randomized control study. So, has any of you seen alcohol dependence patients or you have heard about alcohol dependence? It's quite a bad thing. It's quite common in India for people to have alcohol dependence. And there's a drug called topiramate. So the main story is, does topiramate cause decrease alcohol dependence? And the researchers were interested to know whether the gene, this particular gene RS2832407, whether that gene, I don't know, psychiatry, whether you all do some gene analysis. So whether that gene is an effect modifier. I'll explain the story. This graph may look complicated. Let us just take the first part of the graph. So all patients began at this point, study week 0. Some of them got placebo, which is in red. Some of them got topiramate, which is in green. Yeah. As time went on, they're looking for heavy drinking. So if you're coming down the ladder on the y-axis, you're doing better. So you can see that overall the topiramate group started doing better. From very quickly onwards, they were doing better. And the placebo group also did better, but not as well as the. So this is a effect, overall effect. Now we want to know whether there is effect modification, whether the effect of a treatment is different in groups of patients with different characteristics. So what are the different characteristics? So that gene RS283, if you have both in your genotype, it's called CC. If you have one of the pair in a gene, it's called AC. If you have none, it's called AA. So you get one from each parent. So if you have both your parents have given you this gene, then it's the CC. It's a homozygous genotype. Anyway, you can see from this picture that only this group of patients, there was a difference between placebo and topiramate, whereas other people, there was not much difference. So this is exploring in which group can I particularly target and give. Of course, if you don't have that gene in your hospital, then you can't. You give everybody topiramate. Yeah, so this is effect modification in a randomized control study. Again, if you have questions, please ask me because you're going to do all this in the analysis in the methodology. Effect modification in a cohort study. Now you know that this Bill Gates, they do this million death study in India also, and then declare that so many people more died of malaria than we are admitting. So this million women study, all that kind of a study, million women. One of the questions they asked is, if you give hormone replacement therapy after menopause, hormone replacement therapy, whether it will reduce endometrial cancer. So there's a lot of hype about HRT. Some say very good, some say very bad, some say no use. So the question was whether hormone replacement therapy will reduce endometrial cancer in a cohort study. This is different from randomized study where some people by a random process are given drug A and drug B. Here some women chose, or the doctor told them to take, and some people decided not to take, either the patient themselves or the doctor. So what did they find? So the risk of cancer is relative risk. And they were looking, remember, I'm trying to look at subgroups. So the reference group is people who never took hormone replacement therapy. And the group above is the one who took hormone replacement. These are people BMI less than 25, 25 to 29, more than 30. And you can see that the relative risk, the odds rate, the confidence interval should not cross 1. If it crosses 1, there's no difference to the reference group. Here also it looks like less than 1, but the confidence interval 0.6 to 1.3 crosses 1. So there's no difference. But in the BMI more than 30 group, there is a difference. 0.28 means significant protection from endometrial cancer, and the confidence interval doesn't cross 1. So we'll say that the main effect was consistent only in the subgroup BMI more than 30. Is that okay? So this is effect modification. Next is interaction. The term is going to sound very similar, but you must now start just thinking that there is a slight difference. What is the difference? We're looking at two simultaneously. Like if fighting a war, they say that if India can defeat China, India can defeat Pakistan. If India has to fight China and Pakistan, that's a bit much. So what's the effect of both together? Is the effect 1 plus 1, or does the effect of fighting against them become 4? That means it's more than just 1 plus 1. Or maybe 1 plus 1 becomes 1.5. It's maybe less than fighting both. But that's a general picture I'm trying to give you. Of course, it's a silly example. I sincerely hope that doesn't happen. Synergistic interaction means 1 plus 1 becomes 3, 4, 5. Antagonistic interaction means 1 plus 1 becomes 1.5, not 2. It becomes antagonistic. So this is slightly different to effect modification. In effect modification, we are just looking at only one thing. We're looking at whether hormone replacement therapy reduces endometrial cancer. Only one way, that's all. In that story, is there a difference between 2 groups or 3 groups of people? In interaction, there are 2 exposures we're looking at simultaneously. So how does it work? Let me give an example in a randomized control study. I'll just use the whiteboard. I hope all of you can see. So the story here is called a factorial design. In a factorial design, there'll always be 4 arms to the study. So they're looking to see if I can prevent heart disease, thrombosis prevention trial. These are all real data. The question is, should I give aspirin or should I not give aspirin? Previously, everybody after 50 took aspirin. Now suddenly aspirin went out of favor. If you take aspirin, you'll have more GI bleed, stop aspirin. And some people said you can give warfarin, an anticoagulant, to also prevent heart blood vessels clotting up. So what happens if you give both or neither? So to prevent ischemic heart disease. So you will have a group with aspirin plus minus, warfarin plus minus. So can you see what all the combinations are? Some people can have aspirin and warfarin. This group will have warfarin. Oh, sorry, I put aspirin first. No aspirin, warfarin plus. This group, aspirin plus, warfarin no. Here. So this is a picture of a factorial design. So in your mind, you must think about this factorial design. When you're thinking about interaction, you should be able to make a 2x2 table like this to explain interaction. So a lot of things Dr. J is going to teach you is interaction. So let us have a look at this. Just look at this table. This is, when I move away, can you hear me in the back? So this is incidence rate of heart disease per 1,000. So the lower the incidence rate, you're doing better. So this is double placebo, or this group. No aspirin, no warfarin. So they had 13 per 1,000 years heart disease. Aspirin alone, which is this group, had 10.2. Warfarin alone at 10.3. Aspirin plus warfarin is 8.7. So now we must do mathematics to see is there a interaction effect. 1 plus 1 should not be 2. 1 plus 1 should be more than 2, 3, 4, 5. So the first thing to look at is aspirin among those receiving warfarin. What is the effect of aspirin alone among those receiving warfarin? How do we calculate that? Warfarin alone had 10.3 per 1,000 year heart disease. Warfarin plus aspirin 8.7. So the difference between 10.3 and 8.7 is 3.1. So this is the effect of aspirin among those receiving warfarin. Second, what is the reduction due to aspirin among those not receiving warfarin? That is this comparison. So people taking double placebo had 13.3. Aspirin alone was 10.2. If you minus 13.3 to 10.2, the difference is 1.6. These two differences should have been equal if there was no interaction. 1 plus 1 is 2. Both when you minus 1 from the other, the difference should be 0. The difference here is 1.6. This is also called interaction contrast. So sometimes in literature you'll find interaction contrast or so much. How do you say that in English? If the interaction contrast is 0, there is no synergy, neither positive nor negative synergy. If the interaction contrast is more than 1, how do we say it in English? For every year, because this is looking at 1,000 patient years, for every year if you treat 1,000 people, you will get an additional 1.5 new or 1.5 less heart disease as compared to giving purely aspirin plus warfarin. The benefit you'll expect from purely aspirin plus warfarin, 1 plus 1, not 2, you get 3.5. If you look at that way. That is the way you interpret the interaction contrast. Yes.
So the difference has been changed. Say the first value should be 1.6 and the second one will be 3.1. The difference is
This 10.3 and 8.7 is 3.1, no?
no 1.6.
Oh, okay, sorry. Okay. Correct. So the difference is greater than 1, greater than 0, and you say synergy is present. And the way to say in English is if you treat 1,000 people for 1 year, you will get additional 1.5 life saved or ischemic heart disease saved over what we expect from aspirin alone and warfarin together. You add them together, it's not about that. They're getting another extra benefit, that is silence. Next one, observational studies, interaction. So in observational studies, last one I told you, sir, randomized control study. So this is a true randomized control study, and the study was based on this. You can Google this thrombosis prevention trial if you like to read that paper. This
Instead of aspirin, can we use warfarin or
it's your choice. The decision may be based on safety or cost and other things. But the question you're asking is, am I getting extra? So instead of just adding 1 plus 1, am I getting 2 or am I getting 3 or 4? If I'm getting 3 or 4, it may be to my advantage. But it may also come at a disadvantage of bleeding or something else. So the choice is here. So observational study, this is looking at bleeding. Exactly the question I was saying. If you add 2 or more drugs, you're looking at benefit. But you can also get 2 or more studies, drugs which can give you harm. So aspirin is a drug given after heart attack. Clopidogrel is also a drug after heart attack. What about if I give both together? Instead of getting 1 plus 1 bleeding, am I getting 5 times the bleeding? So harms also can be multiplied by a synergistic interaction. So the just instead of in this 2 by 2 table, aspirin can be there. Instead of warfarin, we'll put clopidogrel. So that's all. So again, this is an observational study. So the same 4 groups. No antithrombotic means this group. No aspirin, instead of warfarin, just imagine no clopidogrel. So the risk in that, bleeding risk in that group is called reference category. Sometimes in tables, the previous table I put it as risk incidence per 1,000 people. Sometimes in papers they give it to you as odds ratio. Odds ratio will always be a reference category. So the reference category for factorial design is always a group which got neither. Compared to that, the risk in aspirin for bleeding is 2.4 times. Clopidogrel alone is 3.1, and the aspirin plus clopidogrel is 12.6. Just eyeballing the result, you know that it's likely to be more than just the effect of aspirin alone and clopidogrel alone. So what do you say? How do you make this into a relative risk? Odds ratio to relative risk. So you take 12 and you minus these two, 12.6 minus 3.1 minus 2.4, but you add 1 to make it into a relative risk. So 12.6 minus 3.1 minus 2.4 plus 1 is 8.1. So how do you say that in English? The likelihood of bleeding is 8 times more when you combine aspirin and clopidogrel as what you would expect by just adding aspirin and clopidogrel. Something happens when you add both together, the risk of bleeding becomes 8 times more than what you normally expect by simply adding aspirin and clopidogrel. So we must look at benefits and harms in interaction. To change odds ratio to a risk, converting odds to risk. Next, we move to again effect modification versus interaction. In effect modification, if I'm looking at only aspirin and bleeding, then I'm just asking does aspirin cause more bleeding, and the effect modification will be clopidogrel. So clopidogrel plus minus. I won't have this 4 arm. I'll just have aspirin causes bleeding in the group with clopidogrel, yes or no. That is effect modification. So only one effect. You're really interested in aspirin, and you're comparing in 2 subgroups. So you're not interested in the clopidogrel alone and the clopidogrel interaction. Yes. Okay, that's all. Next, we come to mediation. Now there's always fighting. Israel and Gaza is fighting. There seem to be some mediators. So in research also we're looking at mediators. What mediates a story? Does alcohol cause heart disease or there's something on the pathway? Does smoking cause lung cancer? Okay, no, smoking actually is good. Smoking causes lung cancer, but the nicotine goes inside and then it causes some DNA change. So the effect of smoking is mediated through nicotine. So that's the story we're trying to ask. What is there in the pathway? Is there an intermediate or a mediator between the exposure and the outcome? That mediator can explain everything. The whole effect of smoking and lung cancer is explained by nicotine. No, there's so many other explanations. Nicotine-free cigarette also is causing lung cancer. So the mediator could explain partially or wholly. So in practical terms, why do we study mediation? So in practical terms, We may not be able to target smoking, but we may be able to reduce nicotine levels by giving some particular effect. Some mediator may be easier to work on than the exposure itself. That's why really we are studying mediation. So let's have a look at one example. I don't know if any of you had backache, quite a common thing in the world. And the commonest drug previously was painkiller. Commonest drug was painkiller, but now everybody started giving this new drug, pregabalin. Very good. I don't know if any of you had pregabalin. So you pop pregabalin, you sleep nicely and feel nice the next morning. So the question is, pregabalin gives nice sleep. I'm sure psychiatrists are horrified. Guys, please don't start prescribing pregabalin for sleep. But it has a good sleep effect. Is the effect of sleep purely because pregabalin gives sleep? Or does pregabalin reduce pain and therefore reduce sleep or increase sleep? So is the effect of pregabalin mediated by pain, or is it directly just giving you good sleep? This is called intermediate or mediated effect. The effect which is not because of this is called a direct effect. The total of direct and intermediate is called total effect. Okay, right? So you have some, what can you explain as an intermediate? This may explain 100%, this may explain 0%. You're trying to see if there's some intermediate. This is the story of my next slide. So the effect that acts through the intermediate is also called mediated effect. This one, mediated effect or indirect effect. That is not explained by intermediate is called direct effect. This one is direct. The total is both together. So this is a randomized control study of people with myofascial pain or Kaikalvali or whatever syndrome we want to call it, various names in various parts of India for unexplained body pain. People used to think it's just something made up in the mind, but now we know it's very real. People do have that, and it can be quite devastating for people who have it. So they looked at the effect in this randomized control study, and the outcome they were looking at sleep quality score, mean change. So in the people who are pregabalin, the total effect, both direct and indirect, was minus 1.29 on the sleep quality score. The effect that was mediated through pain reduction, so this is the mediated reduction, was 0.718. So this is a mediated effect. So 0.718 divided by 1.2 is about 55%. So we'll conclude that 55% of the effect of pregabalin on sleep is due to pain reduction. So what? What is the big thing of finding out that? Now we know if you're a pharmacologist or a physician or somebody interested in mechanism of disease, much of the effect of pregabalin is really pain reduction. But as a pharmacologist or as a scientist, you may also think, hey, then if I want to reduce good sleep to the next patient who can't tolerate pregabalin, I will target some drug which reduces pain. That itself may give sleep because decreasing pain seems to reduce sleep. So the knowledge of intermediates can help us in future research. That's why we study mediation. Now I told you this is a randomized control study. We can look at the effect of mediation in observational studies as well. So I'm trying to give examples from intervention studies and observational studies as well. In observational studies, one is called case control study. The case in this example is people who had deep vein thrombosis or blood clot in the leg, and the controls were people who didn't have blood clots in the leg. The exposure was O blood group. Anybody has O blood group? Only few. Okay, seems to be rarer than I thought. So they thought that O blood group may be a risk factor for, I hope none of you have DVT, but that was a question they had, whether O blood group causes deep vein thrombosis. They were not sure how does O blood group cause deep vein thrombosis. The question is it mediated through factor 8? The main question is, does O blood group cause deep vein thrombosis? Case control study, you start off with the case, DVT, controls without DVT, and you just look in the past because your blood group doesn't change. If you take the blood group at that day also, it's the same as what you had from birth, O blood group. And they measured in that both groups the factor 8 to see whether it was the mediator in this story. So the effect of, total effect of O blood group was 2. The direct effect that is not mediated by factor 8 was 1.5. And this is odds ratio for, in a case control studies, I will teach you do odds ratio. So the total effect was 2. for DVT and blood group O. The direct effect not explained by mediation was 1.5, but that still says that there is 0.5 mediated by factor VIII. You may choose to say that's not significant, or you may say that is significant, that's up to you. But you are able to explain or understand a process, disease process, that some of the effect of blood group O on causing DVT is mediated through factor VIII. This is mediation. Independency. So when you plan this interaction, some people will say that two factors should be independent from each other. You are looking at an interaction between two variables. Should they be independent of each other? Logically, it's very outside an RCT, it's very difficult to make this 2x2 table to see whether that really there's an interaction or not. You should be able to make out the data in all four groups separately. Otherwise, you can't really tease out the effect of the interaction. Sometimes environment and behavior may have an interaction. So you'll be careful of that. People who are poorer neighborhoods don't have parks and recreation activity. So they may land up having some other bad habits like smoking. So there's lots of interactions and they may not be truly independent. When you do mediation assessment, we presuppose that there is no interaction between the exposure and the mediator. There is no interaction between smoking and the nicotine. There's no interaction between those two terms. We don't do an interaction assessment. The clinical question posed in mediation presuppose a relationship among exposure, the intermediate, and the outcome. The effect of the exposure on the outcome could work via the intermediate, irrespective of the intermediate, or both. Usually, when you do statistics, we do not do an interaction between the exposure and the intermediate. That's a general, we don't try to do interactions between those two. So, you must be careful of that particular thing. The next thing I want to talk about is measurement error. Now, this is not talked about often. If you want to measure how much alcohol one drinks, if you say, somebody says, I drink once in a while, sir, I know fully well you're drinking daily. I drink 30 ml means probably you're drinking 180 ml every day. This is measurement error. So measurement error can affect many things. First of all, it affects sample size. As Jesa will teach you, sample size largely depends on the error you are willing to allow. And if the measurement itself is erroneous or has a large variation, sample size will change. It can affect effect modification and interaction. So be careful of that. If your measurement, what you're calling each variable, whether aspirin was there or warfarin was there, if these are not measured correctly, that will affect your interaction as well as effect modification. They can produce interaction where there is none. They can produce effect modification when there is none. Sometimes you have very little bit of error terms, like for example, if you have genetic gene testing, so very often people use genetic markers because they are less prone for error testing. In mediation analysis also, when look at mediation, errors can affect the validity of mediation. So be very careful when you're doing research, the quality of each data you pick up. That's also a part of systematic error. Once you collected the data and done analysis, nothing can help you after that because that is the quality of your data. So be very careful of the quality of data. It can affect effect modification, interaction, and mediation analysis. You may falsely conclude interaction, mediation, interaction, which may be all due to poor measurement of your variable. The next 15-20 minutes, I'm going to take you through something which I like. It's just revision of what I told you so far. So if you're not interested in pictorial, I love this. This is called directed acyclic graph. Has anybody here done direct DAGs before? No? Okay, then just think of it as fun. So in this directed acyclic graph, E stands for the risk factor you're studying, and D stands for the disease. E is also called a node, and the arrow represents a process. E leads to D. The exposure leads to disease. So this particular kind of showing a relationship in your research is called directed acyclic graph. So there's a causal question. What is the question? Exposure leading to disease. And you're really interested in all these other stories. Don't worry about all these other lines and stories. I'm going to take you that in the next 15 minutes. But other than this, what else is muddying up the story? Remember, I told you lions, bears, camels, goats. Those other lions and nodes are all the camels, goats, and bears that you will meet across in research. You are really interested only in this, right? So we'll go one by one. What is that error term I told you? Each of these other things, the exposure itself may not be measured correctly. The disease may not be measured correctly. So even that can affect your research. So inherent in this picture is you should be careful of that error as well. Now, between the exposure and disease, this is causal. M stands for mediator. That's also a causal relationship. I'll explain it many times. Non-causal pathways. You see, there's something called C and something called G. That's not directly lined here. So that's called a non-causal pathway. It also seems to lead to D. There's another one. E leads to S. L, something else called L, leads to S. So these are non-causal pathways, and I'll explain them, why I'm talking about these two, and why all of you should make a picture like this before you start your research. Before your regression analysis, each of you must make a picture like this. What is C? C stands for confounding. So if you're looking at the effect of obesity on death, C could be diabetes. Obese people are related, diabetes is related to obesity, diabetes is related to death. Diabetes may cause heart disease causing death. So then this is an intermediate between these two. So in this story, C is the confounder. I can take care of the confounder in my analysis. Dr. J will teach you how to do confounded analysis. Either I can adjust for C or G. I should not do both. That is why one must draw a picture. Otherwise, you'll end up doing wrong analysis. We'll come to that in a little while. M is a mediator. You must also be aware that it's a mediator. When you adjust for it, it's a mediator you're adjusting for. Maybe you should not be adjusting for the mediator, unless that's what you're looking for. S is also called collider. S is a collider between E and D. So you can see that the arrow from E to D is a straight arrow. M to D is a straight arrow. But here you see there are two arrows in a picture pointing towards each other. That's called a collider. We'll explain collider in a little while. In examples, D is a descendant. Z is a descendant of D. Let us say stroke is the outcome. And following stroke, how many people had pneumonia? So pneumonia is a result of having had a stroke. You should not adjust for stroke when you're studying for, adjust for pneumonia when you're studying for stroke, because it is a result of having had a stroke. Only when you draw the picture, suddenly you say, oh, that happened after my outcome of interest. So I should not adjust for that. That's called a descendant. I is called instrument variable. I'll talk about a little bit more about that. Sometimes all these, when you're doing the research, you'll find, oh my goodness, there are so many confounders, interaction, mediators. It's all over the place. I don't know what to do. That's why people do randomized control studies. When you go to Kavita or Dr. J, they'll give you a randomization code that takes care of 90% of all of these. Not 100%, probably 90%. So I is called instrument variable, usually randomization. I'll talk a little bit more about some other types of randomization. J in this story is called effect modifier, and that's what I talked about earlier. What is an effect modifier? In the topiramate alcohol dependent, the gene was the effect modifier. So this is just the pictorial representation of the same. Now, causal pathways, when you're drawing your own DAG, the arrow should all be in one direction, E to D or E to M to D. Non-causal pathways, the arrow is going a slightly different direction. So C to E, C to G to D, these are all non-causal pathways. These on top, I have labeled as confounders, C and G. S is the collider. Let's learn about confounding. When do you say something is confounding? Remember, I told you I'll speak more about confounding in detail. If it is related to both the exposure and the disease, the arrow must be there in both places. So here I could have put directly C to D. I put G because, again, why did I put G? Can somebody give me a reason why would I possibly put G in the story? Adjust for either one, not both. Maybe one is easier to measure. Maybe one I know that's very poorly measured. Maybe G is much more accurately measured. So I can trust in G. So therefore, I will only adjust for G because I know the C is not very accurately measured. So you must have a picture of this with you. And therefore, you decide to put this picture G in this argument. So if one looks at coffee drinking got heart disease, so coffee drinking is the exposure, heart disease is the disease. But actually, coffee drinkers smoke and smoking causes heart disease. Or other smokers drink, smokers have heart disease. So this is an easy way to look at this confounding picture. Yeah, any questions? Okay, if one were to draw equations, are you all familiar with equations? Yes, no? How many are familiar with equations? Okay, that's a few. So I'm not very good. This is Dr. J's area. So I'm just going to take a shot at it. That's okay. So if one looked at the relationship between weight and height, you'd probably get something like this. As from birth, as you grow older, you'll get, as you grow older, I mean, not older, as you grow taller, your weight increases. If one were to put, this is Y axis, this is X axis. If one were to make an equation, we'll say Y is equal to something times X. So as this increases, this increases. So as if there's a 1 unit change in X, how much is the change in Y? What is that called? Slope from maths. Slope. I hated maths. So when there's no height when you're 0, but when the X value is 0, there's always some Y value. So you'll always put a constant. This is a regression equation. So from this one can determine, if I know X, I can, and K, I can say what the expected Y will be. This is a simple equation. In this equation, I know there'll be some error terms, some confounders. The confounders may be measured. Measured confounders are called observed confounders. And there'll be some unobserved confounders. They also will be contributing to this. You think there's only X is contributing to Y. There may be something else. So in some equations, people call it as an observed confounder. And you realize that you don't know everything which may, in the whole story of life, there may be so many things we'll discover later. We just call them all totally as unobserved confounders. And the end of it all, we'll put one error term, E, because there'll be some errors which we do measurement or some other error which we are still left with after this whole story. So that is this, what looks like a confusing equation. The unobserved error is also called endogeneity bias or hidden selection bias or omitted variable bias. So basically they're saying that there is some bias which we don't know. So we just call it that, unobserved confounder. So this is an example. It's published recently, a month ago in the Lancet, and it's a hot topic. Whether diabetes is related to COVID, whether diabetes is related to vaccine, it's a big deal because India already has diabetes capital of the world. Whether COVID gave us a free gift of extra, whether vaccine gave us a boost of diabetes or it reduced. I'm not taking the whole story, but this is a paper from the current Lancet. But the real story was the incidence of diabetes after COVID. So COVID was the exposure. Incidence of diabetes was the disease, or the disease was diabetes, and the measurement is incidence. So in the paper they have given confounding variables: age, sex, ethnicity, socioeconomic deprivation, smoking. Socioeconomic deprivation, they use the PIN code as a marker because they know that which parts of UK people are poor, which parts are rich. So that's an indicator. So people in the US will say, tell me your PIN code, I'll tell you your health. So I'm sure in India also, we know there are poorer areas, richer areas in every city. And they had so many other comorbidities, heart disease, angina, blah, blah. All these are called confounders. We're looking at COVID causing diabetes. But we know that so many things can cause diabetes. So these are all confounders. So when they present results, they say the adjusted hazard ratio. Adjusted hazard ratio means they adjusted for all these variables. So when you're all doing now confounders and you're doing adjustment, you have to list down all the confounders preferably make a picture and show where the confounder fits in the picture. The adjusted hazard ratio was 4.3, adjusting for all this. Of course, the adjusted hazard ratio was different in the first 4 weeks after COVID, and it came down to 1.24 after about a year, 53 weeks, nearly a year. So this is the real how people present. When you say adjusted results, adjusted for confounders. Yeah. Yes. No, G is an intermediate on the pathway. You should not adjust for G and C. See, let us say smoking, and this is nicotine level. Either you can choose, nicotine comes because you smoke, but you know nicotine level is very accurate. Smoking data is very poor because people are not telling you correctly, but I have blood nicotine level or higher nicotine level. So therefore, I adjust for the nicotine level rather than smoking. I should not put both into my story. As we'll come to the conclusion of this, that some people take every variable they have put it into a adjusted analysis. That is wrong. Okay, so how do you, if you are a researcher doing research, how can I reduce confounding? One is I can get a good study design which has less confounding. So randomized control study is obviously the one with the least amount of confounding, but the most difficult to do. If I'm looking at smoking and lung cancer, I cannot say you smoke and don't smoke. If I want to know whether parachute save life, it's a joke, obviously. You can't tell some people, why don't you jump off and let's see whether you die. So we can't do randomized control studies in many situations. What we can do, crossover design. You take the drug for some time, and after some time you stop taking the drug. You don't take the drug initially, then you start taking. So it's less confounding because you're comparing against your own self. So crossover designs. Monozygotic twins is the next alternative to randomized control studies. Everything is same, probably the birth and the environment and everything, except the drug or the exposure is different in both of them. Observational studies, you can learn about restriction. You restrict the analysis only to a certain group of people so that there's no confusion. Matching, you can learn cohort studies, how to do matching. There are many techniques in matching. These are all study design based. If you're in the statistics, the sixth one is what you're here to learn about, modeling. Regression is a modeling technique that Sir and Kavita will teach you about. But there are some other statistical techniques: stratification, standardization weighting, indirect standardization, pooling, inverse probability weighting. We're not going to go through all of these. There are other tests for completion's sake. You can Google, you can see on YouTube how to do all of these. They're easily done on SPSS or any software. What is residual confounding? Remember that after all the confounding, there'll be some confounding left over. So you know that there is something which you couldn't explain. There must be some confounding which is still left over that people call residual confounding. Either it is because the study design was poor, or in the analysis I couldn't do everything I wanted to do. So there'll be some, always in your mind you must do, when you read observational study data, there will be some residual confounding. So when people say in an RCT, the drug works, we are sure it's like we say causing. This drug reduces death because there's very little confounding. A well done RCT. Even the best cohort study, people will always be little hesitant to change their practice because there is some residual confounding which may not explain the whole story. Something there which we didn't measure, which is always there. Now I'm taking from the internet. This is a guy called Kenneth Rothman. So this is a book we used to read sometimes in statistics in EPI. And I just want to read this quotation that he wrote. The research process of learning about and controlling for confounding can be thought of as a walk through a maze towards a central goal. So if you look at that picture which I showed you, it's quite a maze. I am only interested in exposure causing disease, but there are so many other things in this maze. The path through the maze eventually permits the scientist to penetrate into levels that successively get closer to the goal. So every time you do the analysis, you become a little more clever. So what I advise all of you, do analysis, then go back to statistician, meet your team members. Do you think this is the correct story? Do you think we have analyzed everything correctly or not? Then you can successfully keep on doing. So don't just do one adjusted analysis and say that's the end. See, these students sometimes may do everything wrong because of lack of time. But I believe doing the regression is a continuous technique. That the clinician meets the statistician, Look at the results. Go back to the drawing board. Have I adjusted for the right variables or not? And keep on going back to that picture. So the example of maternal age and Down syndrome. This apparent relationship between the birth order can be explained by the mother's age. So initially people thought Down syndrome is really the fifth or sixth child will have Downs. But actually the whole story was age of the mother. That was a confounding variable, which was not evident initially. So that's something which has to be explained. So as you do this confounding, slowly we'll come closer to the truth. So as you slowly adjust for one and more confounders, we hope we are coming closer towards the truth. But a journey in biology never ends with the end of the adjusted analysis. At the end of your adjusted analysis, you'll always be left with some questions which are unanswered. So confounding is a very interesting thing, nice to do in research, but don't think that that's the end. There may be some part which is unexplained. When Sir takes class, he'll tell you R square value. How much of the outcome is explained by all the variables in your equation? How much of the Y is explained by all the variables you put inside? There may be some part unexplained. So you learn about R square, AIC, BIC, some strange words. Then you realize, oh, there's more to my story. Very rarely people publish that in the results because it looks like they're shooting themselves. But actually, that's not correct. After your research, somebody must take on and do more research. So a little bit about statistics. These slides are not there. I'll share this with you. So if you have a relative risk, crude relative risk, and an adjusted relative risk. So I told you in this picture, sorry to go back. This is the adjusted hazard ratio. You can take it as adjusted relative risk. So the adjusted hazard ratio was 4.3. So suppose we get in our story, adjusted hazard ratio 4.3, crude without adjustment may be 5, and you divide it by the 5. That is the magnitude of confounding. I told you if the confounding is more than 10%, 15%, then we'll say that's some amount of confounding by that variable. Some other people put a slight difference. Actually, I made a mistake. The second one, just I'll put this. I'll share the slides again. Crude minus adjusted divided by crude. This should be crude minus adjusted divided by adjusted relative risk. So there are two ways of calculating this confounding percentage. I made a mistake. That should not. This is crude. This should be adjusted. So let's give an example of confounding in mathematics. Suppose the crude odds ratio, risk ratio for obesity causing death is 1.8. Obesity leads to death. Now I'm doing a stratified analysis. People above the age of 80 years, the risk was 1.4. People below the age of 80, risk is 1.4. Is there confounding? Yes, it changed. The estimate changed. So there's confounding by age. It's same in the two strata. How should it be? It should be the same as this, right? If there was no confounding by age, it should be 1.8 in every age group. There's confounding by age group. So suppose the crude estimate is 1.8, more than 80, 1.8, less than 80, 1.8, no confounding by age. Crude is 1.8, stratum specific, more than 80 is 2.7, less than 80 is 1.1. Now you'll say there is effect modification by age. Okay. If it was confounding, both would have been same. What about, can you have both? Crude risk ratio is 1.8, more than 80 is 1.4, less than 80 is 1.1. So both are less than the crude. If both are less than the crude, both confounding and effect modification are present. It could be the other way also. Both could be more than the crude. More than 80 could be 2 and more than less than 80 could be 2.5. So if you look at it this way, this is a simple interpretation of effect modification. So another way of effect modification and this one, look at this slightly different. Above 80 is more than 2, less than 80 is, more than 1.8, less than 80 is 1.1. So there is some amount of effect modification. Is there confounding also present in this equation? Here you do a little bit of maths. There is an equation called Mantel-Hansel equation. And in that it will tell you the percentage. If it's more than 10% of crude, the adjusted odds ratio or the risk ratio then you say there is some amount of confounding. Okay. So how do you know there's confounding in this situation? You must do a Mantel-Hansel equation. Yes. See, if there is no confounding by age, more than 80, less than 80, it should be same. The overall adjusted risk ratio 1.4. It's a real example. And then the less than 80, more than 80 should not make any difference. There should not be any difference. It is making a difference. If it is crude as 1.8, it's coming down to 1.4 in both groups. It's different. It's different from the two separate groups. How is that? Hey, that's not fitting. Why? Because it's a confounder. Age is confounding your overall story. There are confounders in your story. So you're saying that this 1.4, 1.4 should have fit into that, right? If there was no confounding, that should have happened. Your correct question is correct. Yeah. How can the two groups average be different from the overall? Correct. That is the confounder. Age is a confounder. This is a place. What you're expecting is this. It should be 1.8, 1.8, 1.8. Correct. This is what you're expecting. If I divide population into groups, the average of those groups should be the total group, right? That's mathematics. That's how the equation will come. If you have all the data, you just give a crude, you'll get that. If there was no effect modification, there's no confounding, all the subgroups also will give you 1.8. When you see this, you must suspect, oh, there is confounding by age. When you do the practicals in SPSS, this will become quite easy. We'll give you these slides. So next, mediators. Let's have a look at some examples of mediators in research. So you have effect smoking, or let us say diabetes or obesity causing death. And there may be some mediator. Obesity may be mediating that through some relationship. So this is called mediator. You should not control for the mediator when you're looking at the effect of E on D. In the overall, don't simply add mediator without realizing what you're doing. It is not a confounder. You must be careful when you're doing confounding, adjusting for confounders. Do not add the mediator unless you're specifically looking for mediator. That will only come if you make this picture. So that's why I'm urging, that's why I'm taking little time from your workshop for this. Now this is again a current paper published in August 2024 in the Lancet. Risk factors for bad outcomes in TB. So the TB patients are there. That's the disease or exposure. Outcome is bad outcomes. So what mediates a bad outcome? Everybody has TB. Somebody should get well, some don't get well. What are the mediators? So they looked at many things in this particular story. Race, but they think race is a social construct. Race is a historical bad thing, which led you to poverty, which led you to blah, blah, blah. So that race is not your race, but race reflects something underneath. Anyway, they took many other things, comorbidities, poverty, unemployment, blah, blah. They were looking at what mediates bad outcomes in TB. I'm not going to take you through the DAG which they have made, but even Lancet, the current Lancet, usually they won't put it in the main paper. If you look at the supplementary appendix or supplementary files, there will always be a picture explaining what the analysis they are planning to do. In an RCT, you don't have to do it because there's a consort figure. In observation studies, people do a strobe figure, but that's just a flow of patients. It's not the flow of thought. The DAG is a flow of thought. What happens? How does it just go to this? So what did they find? The bad outcome was if you are diagnosed with TB at death, autopsy found you to have TB, or you discontinued treatment, or you died during treatment. The total effect was 1.32. The mediated effect was 1.2. These are the mediators which they were studying for, like race. So they said overall the mediated amount was 67%. So you just kind of give an explanation. They're not telling about confounders. How much of the bad effect was TB was through these particular mediators. So you can present mediator analysis as well. Just 5 more minutes. Coffee next. So I'll just take 5 to 10 minutes of your coffee break. So colliders. I told you I'll talk about colliders in some more time. Colliders I found a bit complicated. It's not that complicated if you think about it, but collider analysis is very important. So colliders are called because they have two arrows pointing towards them. They're on. So the main important thing about collider is you should not adjust for colliders. So sometime in research, someone says this is a potential collider. Please don't adjust for that. It will cause spurious relationships in the whole story. So don't adjust for colliders. So let me give an example. This is if you're interested, if you find it confusing, a nice website. Just Google on YouTube Norman and collider or Bergson's paradox. Nice videos explaining this. So this is a screen grab I've taken. I've copy lefted it from his YouTube. Or I mean, sorry, his paper. This is the paper. I've given you the PDF from the paper. So what is this collider or Bergson's bias? So the paradox is we believe that attractive people are more likely to be unpleasant or mean than nice. Beautiful girl, but she's unpleasant. Or handsome guy, but he's a nasty fellow. That's a general thought. It may be wrong. And that's called collider bias or Bergson's bias. So what is that? So people could be good looking or average looking. They may be very nice or they may be quite unpleasant. Okay. So just saying. So if you look at who you may want to date or go out with, if you don't think that's appropriate, who you want to have as a friend, you're likely to have a small number of people who are good looking and nice. You may have many people who are good looking because you're first attracted to looks, and then even if they're not so pleasant, you're still wanting to be their friend. And you may have some not so nice looking people, but they're very nice. You're unlikely to have as friend not so nice looking people who are quite nasty. So if you don't know about this, but if you look at the number of people who are your friends, most of them are good looking and more of them are nasty than not nasty. So you will conclude wrongly that most good looking people are nasty because you restricted your analysis to the people who you looked at only as your friend and not at the entire population. So often this collider bias happens when you do subgroup analysis of one particular or you restrict your analysis to one particular group of people, and then suddenly all sorts of odd relationships start to occur. You conclude that good looking people are often nasty. Let me give another example. Depression causes poor health outcomes. Social isolation can cause depression. Social isolation can cause poor outcomes. So it's called a confounder. Now, if you put volunteers, please take part in the study. Who are the people who volunteer? Depressed people tend to volunteer. People who are poor and not feeling so good or have some bad outcomes may be the participants. So if you restrict your analysis to only few people who came to your hospital, you may land up with a collider bias. So you should not adjust for the collider. Let me give one more example in the next slide. Okay, on top of the picture are people with obesity. In green are people who smoke. In yellow are people who don't smoke. Below are non-smokers with obesity. These are smokers with obesity. Now, my main picture is mortality without obesity is 13%. People who died are in the black. So mortality in those without obesity is 13%. Mortality with obesity is 16%. So more people who are obese tend to die in the future. That's probably the truth. Okay. Now, from this group, I cut off half the people. I take the subgroup with diabetes. So I'm restricting my analysis to people with diabetes. What do I find in the story? Mortality without obesity, I don't know if I'm blocking your view. Mortality without obesity is 22%. Mortality with obesity is 21%. It appeared suddenly that obesity became protective. How do we explain this sudden change? Because we restricted our analysis to diabetic people. I'll try to explain it a little more in the next slide. So there's 0.5% lower in obese than non-obese, whereas otherwise it was 3% more in the obese. So what is this apparent association between obesity and mortality? Protective, this is called collider bias. It should not be interpreted as causal. It happened because we restricted the study population to diabetics. Now, remember I didn't talk about the smokers and non-smokers. So that's one thing which caused, there's an L in the first picture I showed you. Let us talk about that. Smoking diabetic subgroup, difference in the smoking among obesity and non-obese. So what happens? Because smoking increases mortality and obese individuals in the subgroup with diabetes are less likely to smoke than non-obese individuals, obesity appears to be protective, even though obesity actually increases mortality. There was a sudden hidden problem of smoking, which was different between the diabetics and non-diabetics, and it caused a problem because you restricted the analysis to diabetics. You won't realize any of this when you do a restricted analysis. Some of this is not easily apparent, what is a collider and what is not. You have to keep on going back and thinking about it. Make the picture and try to make the graph. Lastly, descendants. Who are the descendants? Descendants are those who happen after the outcome of interest. So when you do research, you all make a PICO statement, patient group, intervention, control, or exposure, no exposure, and outcome. What happened after the exposure of interest or outcome of interest? That is called a descendant. So we should not adjust for the descendant in the analysis. Don't stratify for it or adjust for it in any of the analysis. Effect modifier, I already talked about. Effect modifiers are here, J. And there are two ways of effect modification. Effect modification could be additive, 1 plus 1 is 2, or it could be multiplicative, 1 plus 1 is 10 or 11 or 12. So the effect could be just a little bit more or it could be largely more. Instrument variables, I told you earlier, instrument variables were previously used largely in economic literature. They try to find some randomization and they do a lot of randomized control studies. In fact, some people got Nobel Prize for doing RCTs in economics. So that's called instrument variable. Now we are coming to the end, last 5 minutes. The potential relationships here are depicted by arrows. And these nodes are the variables. So if one wants to make a DAG, one must do that. If the variable, what happens if you have unmeasured variable? Let us say you make a DAG and suddenly realized, oh, I forgot to measure smoking. Should you show it in your DAG? Yes, you should. So the reader will be aware that this particular confounder is not being shown. What if you have some unmeasured confounder? You know that there's something else. You can just put CU and put it there. Somewhere in my story, there's an unmeasured confounder, an arrow going towards the outcome, an arrow towards the exposure. Because you know there's something more which you can't explain. So you can even put unmeasured, which you know you should have measured, and unknown things you can also show in the DAG. So the first thing is make sure your sample size is adequate. What error will that take care of? Random error. Random error is just chance. The more you study, there's less chance of getting into a random error. The second thing is make sure that you have adjusted for all confounding. You're aware of what are the confounders. Make sure that you are not adjusting for the block, these pathways, L, S. This should not be adjusted for. Colliders. So when do you say something is a common cause? The C has an arrow going towards the exposure and the disease. That's called a C. G is an intermediary. So either adjust for C or for G. S, which has two arrows pointing towards it, is called a collider. It should not be adjusted for it anyway. This could be potentially diabetes in the previous story. Obesity causing death. Diabetes was the collider, which should not be adjusted for. So when can we say E causes D? We took care of sample size, confounding I explained, measurement error. You're pretty sure that every confounder is correctly measured, every exposure is correctly measured in your study, every outcome is correctly measured in your study. You block all the non-causal pathways. All the confounders are blocked and don't block all the colliders. Then you can say E causes D. Okay. So why should you make this whole DAG and why did I take so much time torturing you all when you came to learn SPSS and taking away from your coffee break, coffee getting cold? One is how to tell people. W accounts for the association between E and D. We may say smoking accounts for the relationship between alcohol and heart disease. But what do people understand from that? Is smoking a confounder between alcohol and heart disease? Is smoking a mediator between alcohol and heart disease? When you do the DAG, the relationship becomes clear. Then you'll say, no. Alcohol is a risk factor for heart disease. So E causes D. E is associated with D only because confounding by some other factor. So they're also useful in communicating between colleagues. So nowadays we find that sometimes some computer science graduate will come and join us. We'll have doctors, nurses, healthcare workers, administrative officers, just pure research guys. How will they understand what you're doing? If I want to communicate with Dr. J or Kavita, I need to draw something and tell them this is the story I'm trying to look for. So DAGs are very useful in communicating in a group which is not purely homogeneous. So especially between the researcher and the data analyst, there should be a picture so that everybody is clear what you're doing. So try to make sure that, okay. So in many research in the West, they say this should be figure 1. Usually figure 1 is a flow chart, consort figure or stroke diagram. Nowadays, I put it in the supplementary appendix. So try to find the DAG when you're reading a paper. So very useful for observational studies. Most of us are doing observational studies, not RCT. So even in the DAG, you can represent loss to follow-up. Unexpected mechanism will be the mediator. You can even indicate measurement error. You put an asterisk and say, this variable is poorly measured. So you must know what is confounding, how are you going to account for it? Either you're going to do a study design or what statistical tech you're going to do to avoid, and you may not capture all the variables for confounding. And you must be careful to just wrongly adjust for variables. So if you look at it, you can have potentially many data sets. One with this variable, one without that variable, or models, and the sir will teach you how to make, or Kavita will teach you models. This model has only 2 confounders. This model has 3 confounders. This model has added these 2 together. This model has 2 variables with the interaction term. When to use them, when not to use them, becomes clear when you have the DAG in front of you. When you don't have good confounders, let us say that the study is full of confounding and you can't make any head or tail of it. That's where you must think, maybe I should have done a randomized control study. But that's not possible. So we all are born with a set of genes, and those genes are different from come from half from father, half from mother. And this leads to a natural study. Economists are always looking for natural studies. Oh, in Vellore, they gave COVID vaccine. In Ranipet, which is about 30 kilometers, no COVID vaccine. We can just study the economic impact in the 2 cities. It's a natural randomized study. It's not randomized, which is an example. So human biology, you have a gene, I don't have a gene. It's like a natural randomization. You're born with it. So this is a way of using human genetics as a substitute for a randomized control study. So Mendelian randomization has become very popular in observational studies, especially genetics and other things. To look, it will overcome many of the confounders because there will be a balance between the 2 groups. If you randomize people into 2 groups, a large number, all confounders by magic, known and unknown, will be equal in both groups. That's the magic of randomization. So here, Mendelian randomization tries to mimic that. So this is the second last slide. Some people think that all this is nonsense. I have 30 variables. I'll put them all in my SPSS, click a button, and I'll adjust for everything. I've tried to explain to you why that is not a good idea. That can introduce bias. If you adjust for descendants, if you adjust for blocking variables, then you are going to land up into trouble. If you adjust for mediators, if you adjust for the confounder and its intermediate, again you land up in a lot of trouble. One should not do that. So last example, stroke on functional decline. After you have stroke, people's activities become less. Can't bathe, can't toilet, can't comb hair, can't eat by themselves. So should we adjust for stroke severity? So I'll show this picture. Stroke causes functional decline. I'm studying how much does stroke affect functional decline. The stroke score is made up of how bad your stroke is. So actually it's due to the stroke. So it's a mediator on the pathway. So you should not adjust for stroke severity when you're looking for functional decline, because this is a mediator on the pathway. So very often people look at bad outcome in stroke, they look at stroke, yes or no, put stroke score also in the equation. But the stroke score, or how bad the stroke is a consequence of having had a stroke. It's a mediator on the pathway. You can do a mediated analysis for the effect of how much the stroke score reflects the outcome. That's different, but you should not call it a confounder and dump it into the analysis. I know I've taken 20 minutes more than my time. If you have any questions, I'm happy to answer. There are some slides which I didn't share. I will share that to Dr. Vignesh. Yes, you had a question.
Can you give some examples for instrument variable and collider with respect to medicine?
Instrument variable is Mendelian randomization. So if you're looking at many studies now, they use genes. I take one gene in the population, the absence of a gene in the population, and I can do looking at the effect of smoking and lung cancer. Because then I can say that what would the two groups are based on their genes. Other than smoking, everything becomes equal because I've taken groups with the same gene or the absence of the gene, and I can look at the analysis in the end. So this is if you look at now, just Google Mendelian randomization, the New England Journal, the Lancet, they're full of studies like this. Of course, it's not a randomized control study. It's an instrument variable. It mimics a randomized control study. There may be some unmeasured confounders which still don't allow. The other thing is when looking at genetic analysis, there are so many genes. So the p-value instead of 0.05 becomes 0.000000 because you can have a lot of spurious interactions. So the cutoff point for Mendelian randomization for a variable to be called significant will be p.000001. And then they'll draw it's called a Manhattan diagram. Which are the variables which cross the threshold of 0.00000? Then that should make sense to you. You may have many variables which don't make any sense. Then you interpret, okay, after adjusting using Mendelian randomization, I think this variable explains this outcome. It's a little cautious, but it's better than saying, I can't do any analysis because all my confounders are not measured or it's too messy at study. That's the example. For collider bias, it's when you do subgroup analysis. I'm only going to take diabetic subgroup. Then you landed up with a big problem. So there's that person which I showed you the picture, Norman. He has given 3 or 4 examples on his YouTube channel. He also talks about, this is also called the obesity paradox, this example which I gave you. So if you're interested, he has got 3 other pictures or 3 other YouTubes, 2 other examples on YouTube of examples. On the same paper also gives 3 other examples of collider bias. It usually happens when you suddenly restrict, I only want this group of people. I don't want everybody. And suddenly that group suddenly tells a different story. You must think, how do you recognize in medicine? In diabetics, obesity is protective. That doesn't make any sense to me as a physician. There must be something wrong. Then probably, is there a collider bias? Bergson's bias? That sort of thing. Okay, thank you.